has given apologies, hasn't she, Julie?
She has, and Rebecca as well.
I think it was embarrassing this when I say we're all here, and I offend somebody who's not here. But, okay, let's get going then. All right, welcome everyone. Happy New Year. I think not a terribly busy meeting so far, so we can sort of have time to discuss things if you wish. Apologies, just to Sally and Rebecca, as you said, Julie. Declarations of any other business in the public meeting? No, declarations of interest. Minutes of the meeting of the 12th of December, any corrections? Action log and matters arising. I think it's all in hand unless someone's got to pick something up. Okay, let's get on to something more interesting then. Item 6, patient story about podiatry. Debbie, can I ask you to introduce?
You can. I just want to check. Oh, Tom's here. I was just going to say I think we were expecting Tom, but he's just arrived. That was well timed, Tom.
Thank you.
As if you knew. So I thought it'd be quite interesting to have a patient story related to podiatry, given that it was on the Quality Concerns Register and is something we've talked about a little bit over the last year. So a story that it's got a bit of a we needed to improve, and we did into it, and a little bit of QI as well. So hopefully will be a good and very interesting story. And on that note, I will hand over to Alan and Tom.
Thank you, Debbie. Thank you. Good morning, everybody. Good morning. Nice to see you all. I'll just share my screen. Give me 2 seconds. Bear with me a second. Sorry.
Don't worry. Don't worry.
Why is it? This is the problem with having too many screens. Here we are. Okay, bear with me a second then. We'll get it right this time, hopefully. And share. Here we are. So if I can just wind that back. Here we are. Let me start that again. Good morning, everybody. My name is Alan, and I'm the podiatry service manager, and I'm here today with my colleague Tom, who is the podiatry clinical lead. And we're just going to take you through a presentation over the next sort of 10 minutes about a patient podiatry journey. I'm going to lead you in, hopefully, as to why we got to where we got to with why the patient went on that particular type of journey, and then at that point Tom will take over and talk you through what actually happened to the patient themselves. So without further ado then, so the first slide is really just to demonstrate what the podiatry profession itself has been going through over the past, since pre-COVID, since sort of 2019 time. And the slide says podiatry practice continues to evolve. It's a it deals with high need, high cost patients with multiple or complex conditions, and a quarter of the population will be over 65 by 2033. They are likely to have more than one long-term health condition, along with increasing frailty. The challenge of meeting these demands for podiatrists is complex and requires ongoing change of working practices. So that kind of just sets out a very broad statement of what's been going on. So what does that mean, and what was the precursor to that? So I can only really speak for the podiatry profession. I appreciate that other health professions and the nursing profession has been going through the same struggles, but particularly for podiatry, the bursary reform in 2017 by the government of the day had a profound effect on our profession and our students attending university. So it says here that HEE and NHS E&I predicted that the number of podiatry vacancies in 25 would be double of that of 2018-19, up from 7% to over 14.5%, with the loss of the NHS bursary. Post-COVID estimates suggest that supply and demand gap for 25 could be higher than over 1,000 vacancies a 27% vacancy rate. Just to bring that back to BHFT and what that means for us, I've got a little note here. In 2019, the podiatry service in BHFT, we had 24 whole-time equivalent podiatrists, and today in this year now, we've got 13 whole-time equivalents. So it has had an effect on us. Moving on. And again, the literature, just to continue with this, just to kind of back up what's been going on, it's that the podiatry have been particularly affected by 2017 reforms to healthcare education funding, which has resulted in a decline in recruitment of students to the undergraduate programmes. And also there was a sudden and significant drop in university applicants in 2017 following the loss of training bursaries. Again, just on that theme and what that means for us, personally, I went to Southampton University and trained as podiatrist. I qualified in 2008. There was 45 students in my cohort. Today, in the first year, the intake of summer just gone, there was 8 student podiatrists taken in for the first year, and this year 24. Southampton University is not going to run the podiatry degree anymore, so that's another hit. It's yet another huge impact on the profession with students just not wanting to undertake the podiatry degree any longer. So what have we done? So apart from making some criteria and scope changes, which I'm sure the board will be aware of, one of our big drivers, one of our big main ways of dealing with this was to outsource our patients to private providers. So in 2021, the podiatry service commenced outsourcing of its MSK patients, which is musculoskeletal patients. In podiatry, we call it biomechanics, and it's to do with people, for example, with flat feet and things like that, people that need insoles. So we outsourced that in 21. And then in 2022, the podiatry service commenced outsourcing of its routine patients to private providers. So just to sum up that point, due to a shortage of podiatry staff, both in BHFT and nationally, the podiatry service routine waits listed increased to approximately 35 weeks by the end of 2022. And just to give a number, put a number to that wait, that was over 5,000 patients that were waiting. To manage this, the service has worked in partnership with 2 local private podiatry providers with an agreement that all patients who are triaged as having a routine podiatric problem are outsourced. So anybody with an urgent or a more needing medical podiatric condition would come to BHFT. Only the routine patients would go out to outsourcing. And work was undertaken in 2022 to alter our treatment and criteria to enable the podiatry service to see the patients with the highest podiatric need. Again, just on that point, in that we adjusted our criteria of patients that we would see, so that we would only see the patients who actually have a necessary foot problem, and we need to see a podiatrist to try and meet the demands of the people of Berkshire. So that's kind of where we are now. And then what I'll do is now I'll pass over to Tom, who can talk about how this affected one of our patients.
Thanks, Alan, and good morning, everyone. So I'm going to walk you through this journey for one of our patients, Mr. X. And I think the reason we chose this patient was because he has quite an interesting journey, and it brings in some of the elements that Alan's been speaking about just previously in terms of the outsourcing and the effects of sort of low staffing, and I guess his medical need and his podiatric need is quite an interesting one to explore as well. So Mr. X, the podiatry service, we received a referral for him on the 21st of October in 2022. And the reason, you can see the reason there for the referral, and this was quite key to why his journey went the way it did. So the reason put on his referral was that he was unable to attend to his own foot health, as no one else could help him. He had dystrophic nails, which were causing a risk of skin breakdown and future ulceration, which would be very difficult to heal because of his long-standing steroid treatment. And we just put in a picture there of what a typical dystrophic nail might look like. So it essentially just a thickened or discolored or crumbly nail. And the key thing for our triaging purposes was that it didn't say that there was any high-risk problem at the moment. There was no open wounds on his feet. It was purely just the management of his nails. So a little bit of background about Mr. X. He's an 86-year-old gentleman. He has a past medical history which includes kidney disease, polymyalgia, and hypertension. Thanks, Alan. So as per our normal operating procedures, we carried out a triaging process once we'd received the referral, and we do that to determine the urgency of the referral. At the time, we determined, based on what was written, that the urgency was a routine referral. So as Alan mentioned previously, we had done a lot of work on our referral and triage criteria. And what we had done is we had shifted away from the previous model that podiatry worked under, where we would look at patients' medical need and we would weight it towards their medical need. So as an example of that, a patient who needed their nails cut would qualify for podiatry treatment purely because they were diabetic. Whereas we now, because of staffing issues, we had to shift to a model where we focus more on the urgency of their foot problem rather than their underlying medical need instead. So because of that, we triaged as routine, and that was done on the 21st of October, and they were placed on the routine waiting list. 12th of January 2023, so just over a couple months later, the patient was contacted by podiatry and offered an appointment with the outsourcing private provider. They had that appointment on the 7th of February, which was in total 15 weeks after the initial referral to BHFT. And at that assessment with the private provider, one of the nails were cut back, and it revealed that there was some pus coming out from under the nail. Cutting it back further revealed that they had a breakdown and a lesion underneath the nail. As per our standard operating procedure with the outsourcing provider, that patient was then sent back to BHFT to continue their care with us because they'd now developed a more urgent problem than they had before. So BHFT subsequently saw the patient on the 7th of March. His toe wound was dressed, and it was determined that he would require ongoing care from BHFT podiatry to have subsequent follow-up redressings. At his second appointment with us on the 23rd of March, there was a bit of a concern. We would have expected by that appointment that his wound, all things going well, would start to shrink in size, might even clear up. We typically see the wounds that happen under the toenail. Once the toenail's taken back, the wound tends to heal up fairly quickly. But this was growing in size, and it was showing some sort of quite alarming red flag signals to us that something wasn't quite right with this lesion under the toe. So because of that, an urgent referral was made to the dermatology team to investigate if there was any underlying dermatological condition that might be preventing or causing this wound. So following that, a complaint came in, and this was from the patient's one of the patient's family members. So actually, the original complaint went straight to the private provider, and at that point, the private provider contacted us to say that a complaint's come through. Now, the original complaint was that the family member felt that by cutting the nail back too far, the private provider had caused this lesion under the nail. We worked with the private provider to reply to that to say that no, these sort of things can just exist under the nail, and it's only when you cut the nail back that it does expose these lesions. So it's very unlikely that it was caused by this. This then led to the complaint coming to BHFT instead for other reasons. So the concerns in the complaint raised to BHFT podiatry was that the family member was concerned at the length of time Mr. X had to wait for a podiatry appointment after the referral. Because the referral had flagged that the patient was high risk, they felt they should have been seen sooner or urgently because of that being flagged in the referral. There was also concern as to why the patient had been seen by a private podiatry clinic who only deal with routine problems. And it also, as having to wait for an appointment, the toes deteriorated to the point where the patient now requires weekly dressings with a GP and fortnightly dressings with podiatry. And also the fact that they're also going to dermatology on top of that means that because this gentleman's an elderly gentleman, quite a lot of stress and hassle having to go to all these different appointments, which is completely understandable. So in conclusion, and a bit of learning from this for podiatry. So on the 1st of June 2023, the lesion was biopsied and it did show that it was malignant. But thankfully by August 23, the wound on the toe itself had actually healed. And so the patient was discharged from podiatry in September. Unfortunately, the the cancer had spread and became lymphoma, or it may have been underlying there already, unsure about that, but the patient's now under the care of the oncology team. And then just a bit of learning from our point of view. So obviously, I guess it's not always clear, and this is kind of made evident from the referrer's point of view, so the GP or anyone else referring into podiatry, what we, at the point they pick up the referral form and start to write it, what we consider as urgent or low risk, high risk. So we're looking at maybe adapting our referral form to make it very clear what we consider a high podiatric need and what would get an urgent triage at referral, so that everyone's aware and it's very clear at that point what our criteria is. It also brought up a quite interesting incident, and we've had a couple of similar situations to this crop up as well, where because podiatrists have access to the ICE reporting system, sometimes we get access to test results before the patient has them, and they could be test results that we're not really in a qualified position to report to the patient, such as whether there's a positive test result for cancer, for example. So it's kind of thrown up that question as to how we manage those situations. So there's been a bit of learning around what we should do and how we should what next steps we should take for the patient without sort of stepping beyond our reach and giving advice that we are not qualified to give. And it also has finally highlighted that, you know, although the outsourcing to the private providers has been immensely helpful and has allowed patients to be seen far quicker than they would have if we hadn't have done it, there are some risks associated with it. And, you know, although this thankfully isn't a very common occurrence, if a patient does develop a high risk problem when they go and see the private provider, there is a slight delay for their care because they will then have to be transferred back to us, whereas otherwise they wouldn't.
I think that was it, Tom. Yeah,
that's it. Yeah, so thanks everyone for listening, and happy to take some questions if anyone's got any.
Thanks so much to both of you. It's really, really interesting. And actually, I guess for lay people like me, you don't quite understand how important podiatry service is. You know, it's not something that sort of hits the headlines all the time. So thank you for that. Very helpful. Julian.
Thanks, colleagues. Yeah, really helpful presentation. Just going back to your some of the earlier issues, Alan, you portrayed quite a sort of pessimistic picture of sort of podiatry. So when I came to your team leaders sort of meetings a little while ago, the team leaders were sort of starting to discuss this. And let me know if I've got this wrong in any way, but Southampton University, very good university, entry requirements quite high. And then people coming into podiatry with very few opportunities for career progression, quite a flat structure. And now you've described Southampton University obviously closing that course. It's not the only course, but it's our sort of local supplies sort of chain. So is the future, couple of questions really, is the future apprenticeships, where podiatry has been a bit slower than other professions to sort of come? Is that the sort of right? And have you any thoughts about, because, you know, podiatry is super clever. I mean, the qualification levels and the level of responsibility, and as Martin just pointed out, the areas they're treating and you know, can have profound impacts. So there's a lot of autonomy. Is there any thoughts around the career structure, so that actually this essential service that Martin described has been really important is secured in Berkshire? Is there any thoughts around those couple of things?
I think so. I think that's a really important point, Julian, in that we've got 2 podiatry apprentices with us now. We jumped on that bus as soon as we possibly could, and we've got 2 podiatry apprentices. We got funding for them, and that was great. And upskilling our current staff. It is sad about Southampton University. It's interesting in that I would need to look into it more, but it's more of a south problem. I believe that in the north of the country, podiatry numbers are still good at universities like Manchester and so on, and in Scotland as well. But in the south of the country, the numbers are failing quite largely. Southampton University are not stopping the course entirely; they're just pausing for this year, and I think that they're going to relook at what they're going to do. But definitely, as you say, apprenticeships for us, I think, are the way forward at the moment in getting our podiatrists back in the NHS again.
Just to add to that, I mean, we have done quite a lot of work on our sort of career progression and the structure of our podiatry service as well. We've created quite a few new Band 7 roles. You know, a lot of the exit interviews we had were around, you know, lack of career progression when you got to Band 6, and so we've created these. If you wanted to go to Band 7, it was really purely a management role that you could go into, and a lot of them didn't want to do that. So we've got these clinical Band 7 roles, which I think has helped a lot. A lot of our experienced senior staff have moved into those now, and I think has created a lot more job satisfaction. And then obviously we've explored the international recruitment as well, which we've so far been quite successful, waiting for them to join. So things have certainly started to improve, and I think we've done a lot of work to get there from compared to where we were 2 years ago.
Definitely. Thank you. Thanks, Tom.
Thanks very much. Aileen.
Hi, yeah, I found that really, really interesting. And the outsourcers that you're outsourcing the patients to, where are they getting their staff from? And are they similarly qualified, or are they qualified to a lower level, hence using them for the more routine activities? And I guess that if, well, I'll let you answer the question and then discuss if that's a risk or not.
Do you want me to take it, Alan?
Go on, Tom. Yeah, you can. Yeah, go on, please.
So they are exactly the same qualified podiatrists as we are. Typically what you find with a private practice in the majority of cases is that they typically focus on one or two things. They'll focus on the MSK biomechanics side of things, as well as the routine low risk problems. I think because they're a private practice and haven't got the backing of the NHS behind them, they stick well away of the high risk wound care stuff. So that's why when we set up the outsourcing, they were quite comfortable taking on that kind of work. Even though they've got exactly the same qualified podiatrists, they're just a bit more comfortable in their sort of setting to take on those routine patients. So in that regards, in terms of risk, there was no extra risk in terms of the qualifications of the people seeing the patients. I guess the risk was more the potential delay in care when they if they did develop an urgent problem and try and come back into our service to be seen in-house again.
Yeah, and the point you made, the fact that you've got access to other systems and things like that, you might uncover more. Interesting, really interesting dilemma, isn't it?
Yeah.
Thank you.
Yeah, definitely.
Paul.
Yeah, I just wanted to. I mean, sometimes when we take out these contracts with these private providers, it's opportunist because we've got funding, or it's for a finite period. It sounds like, given the staffing position and the demands on the service, we're not going to get away from having to use private providers in the medium term, most likely. Is that the view of the service, that we need to probably get into a longer term arrangement with private providers?
For podiatry at the moment, Paul, we're actually looking at bringing our MSK patients, our biomechanics patients, and our routine patients back to in-house care as of sort of like June, July time. And we think that we've made, with the international recruitment that's going on, we've recruited 5 new podiatrists from South Africa and Tunisia, and hopefully they'll be coming sometime early this year. And we've made as much provision as we can to accommodate these patients back in-house again, and that is our firm plan to do that. But who knows? I guess it's always a possibility when waiting lists start to climb. That might be something that we need to revisit again then at that point in time.
Thank you.
Okay. Well, look, thank you, Tom and Alan. Really interesting, and certainly I think you can tell that not only do we think it's important, but it's also to have a light shone on it so we can understand, you know, how you feel and how the staffing is going. So thank you very much for what you and your team are doing, and I must look at my toes now in future a bit more carefully. We'll let you go. Thanks so much indeed.
Thank you, everyone.
Thank you all for your support. Thank you very much. Thank you.
Great.
Thank you.
Okay, that's very interesting. Thank you, Debbie, for that. Executive report. Julian, we'll just take questions, shall we, as normal?
Yeah, I think so, Martin. There's a couple of things. I'll ask just warm Minu up. It would be helpful just at the end of the exec report just to have a sort of debrief. The junior doctor strike has come to an end, and it'd be helpful just to hear from Minu the kind of readout about how he's kind of managed that. But just to say, obviously, the main one there, Martin, really is Debbie's bit on where we are with the uptake is as is, and I'm not surprised because Debbie's kept us appraised through that. The planning guidance, Martin, is we're pragmatic, so Paul and the team will make some assumptions. We'll do everything we think we need to do to get us into a sort of ready position, which is fine. There's no more you can do than that. I mean, there is some risks with it. I heard this morning it might not be coming out maybe towards the back end of sort of January. And of course, what Paul and colleagues won't know is what the implications are for the mental health investment standard, the service development funds, and they're quite significant amounts of money. So in a sense, we will try and keep our own house in order, but sort of where we ultimately land will be again sort of late in the day, which is less than ideal, frankly. So we won't let that get in the way of doing everything we can, but it is unhelpful in terms of long-term strategic planning, decision making. We just heard from podiatry about thinking about what workforce you need to be thinking actively to recruit and all the rest of it. It is a bit frustrating in that regard.
Yeah, I understand. Just on that, I understand that. I'm sure we'd be very supportive of the policy you got there, which is to sort of get on with what you can do. You can't invent what you don't know. So we'll just have to take it when it comes, I guess. But we don't want to stop everything, do we? That would be the worst of all things. Okay, sorry, I interrupted you.
No, just I was going to say then, and sort of from Minu, just a brief summary of how we've managed and the position we're in this time, Minu. It'd be helpful, thank you.
Brilliant. Yeah, so the longest continuous strike by doctors in the NHS, which was last sort of 6-day strike by junior doctors, that ended this morning at 7 o'clock. We followed the same pattern and formula for managing these strikes in the trust since March 2023 when they started, and that involves first securing cover for night cover at Prospect Park Hospital, which is the one area where we need junior doctors to provide safe medical cover. We've never had an issue with that, including the last strikes. I don't know about last night, but I haven't heard anything so far. So I assume we had full complement of medical staff and safe cover provided. During the daytime, we've had no cancellation because of junior doctor strikes in the trust of routine activity. And that is because we design our services such that they are, of course, heavily dependent on multidisciplinary teams, but also consultant middle grade staff and junior doctors we use mainly in a training capacity during the daytime. So you'll, of course, triangulate that with our Guardian or Safe Working reports, so there are no extra hours that the junior doctors have to work. So all in all, and looking back, I have figures for how much we spent, and when you look at the overall NHS figures, we have been very, very modest spenders, if that's the word, on covering the strike period, because we do have to pay junior doctors who are willing to cover. We've also had a lot of goodwill, and I have to say that very professional behavior from our junior doctors, and that is really important. Well, there are several who didn't strike, but that's not the point. They have the right to strike. But even during the striking period, they have been very professional about the whole thing. So I couldn't have asked for more from our medical staff. Thank you.
Thank you very much. It's very reassuring to hear. These are difficult times, aren't they? There's no easy answer, but I think your point you make about professionalism is something that I guess we would hold very dear. Anything else, Julian, you want to ask? Can I just raise the vaccination thing? So I know Sally's raised it in her absence. Debbie, can you add anything more? Is there anything else we can do? Is it just one of those things that's a reaction to COVID or whatever?
Yeah, so regionally, we've actually done very well and done better than some of our local acute trusts, which is unusual because, you know, there's a much more captive audience in an acute trust. It's easier to catch people and fortuitously provide them with the flu vaccine than it is where we're spread across so much. So the fact we've exceeded many of them is I think down to a lot of hard work on the team's part. And yes, it is. We are seeing nationally quite a significant reaction to having had COVID vaccines for the last few years, and the fact that the government were going to take us down a route of forcing people to have vaccines in order to stay employed, and staff are exercising their rights to not have it if they don't want to. And I think this is we're gonna see this impact for a little while to come yet. We are seeing some flu cases this year. We've had a couple of outbreaks on our ward, so I'm not sure if that will make a difference for next year or not.
Okay. Aileen.
It was really just a quick question on the wording in that flu and COVID section. It says, in line with national expectations, a member of the trust board have received their flu vaccination, but no mention of COVID. Is there no? Sorry, carry on.
No, there's no requirement. It is only the flu one that is every year we get a letter around flu to talk about the fact that we should lead by example, should all be having it, etc., etc. And the uptake is directed at flu rather than flu and COVID. Right. Now, whether that will change, but at the moment that is what it says in the national guidance.
Okay, I just thought I'd check.
Yeah, no, you're right too.
Debbie, just on the comparison data, is there any international data that shows a similar trend elsewhere? Because you'd think if it was a sort of psychological response to COVID fatigue, as it were, that you'd see that elsewhere, or was it just a UK issue?
Well, it's an England issue, isn't it, to a degree as well, because Wales and Scotland and Ireland didn't choose to go down the potentially forcing people to have their COVID vaccines.
Okay.
So the wider vaccine fatigue thing, I'm not sure, to be honest with you, but the vaccine as a condition of employment is what has upset a lot of people, and that was an England thing.
Yeah, okay, understood. All right, well, at least we've had ours, so I think. Okay, is there anything else? Oh, Naomi, sorry.
Yeah, just quickly, if I may, Martin, a thought got triggered by the patient story that I wonder if at some point in the future we might look into a bit further. The matter of outsourcing to private healthcare providers, and our approach, and perhaps the approach more broadly by the NHS. The part of this that's interesting is that I was ironically reading an article about this very topic this morning in The Economist, and there is a trend by the NHS to use the private sector to outsource certain services, and of course the funding comes from the NHS and they pay the private sector accordingly. And I'm mindful of the fact that we commission private beds for out of area placements and so on and so forth. But it's not, you know, I just feel a bit mystified about our approach because it feels strategic and long-term in nature. And the risk is that you kind of go down the path and then you kind of yo-yo back, you know, as we do. We seem to be for proprietary outsourcing and then making a decision to bring it back in-house, etc. So, Tamina, you've got the answer, I can tell.
If only that was the case, Naomi. It's interesting because I nearly put my hand up at the end of the presentation, but thought it is a subject of a sort of a more in-depth conversation, I think. Certainly we've flagged as a corporate risk now the working with third-party providers for a number of different reasons, one of which is the level of quality of care that they might provide, our ability to manage that contract, and I think also sitting behind that, private providers in any circumstance, we've talked about this in FIP, haven't we, are able to refuse. They're not, you know, they can set a set of criteria that we might not be able to as an NHS provider. But actually we've got a number of services now where I'd probably describe it as a bit of a hybrid provision, and it is probably worth us thinking through what our ambitions around that are going forward and whether we're happy with that. I know when we very first started using private providers in orthopedics, there was a sense that the private providers were sort of cherry picking the really easy cases, and then if things went wrong, they kind of deferred them back into the NHS. So that created a sort of a double whammy for the NHS providers as well. So I think there are some things to think through, but I guess partly with the staffing shortage and partly with our ability to kind of manage in terms of our finances, demand and capacity at particular times, this is a way of delivering in the future. And I guess really thinking it through would be helpful.
No doubt. And I love the way that you position that, actually, Tamina, because you've articulated the kind of day-to-day challenges, and it'll be different for different services, and there'll be different criteria that we look at and different risks to determine what the decision should be. I guess I'm thinking about it as well from the longer term approach, and what's our vision, if you will, about the role of private practice in supporting us to be the best that we can be going forward.
Naomi, thanks for raising that. I think colleagues, we might think about having in one of our discursive boards a discussion about this. I mean, if you look at the private sector, and Naomi knows it much better than I do, having subcontractors to supply you with things had to be properly managed. The risk had to be properly managed, but I mean, it's part of what you do because it works out better delivery to our customers. So I don't think I have any sort of we shouldn't be dogmatic about it. I think we need to just work through what the best way of delivering for the money that's available to our patients, the best care we can. But we've got to be conscious of these risks and things that go with outsourcing, as Tamina says, and that needs to be thought through. And I think it would be helpful to have just a general discussion so we know, don't inadvertently go down a route we don't want to go down. Julian.
Yeah, Martin, I thought your use of the word outsourcing rather than private provider was better, because we ought to look at also the outsourcing to the voluntary sector, because there's also risk there. So I think it would be useful to have a session. I can envisage sort of looking at where we've used outsourcing to date, and then seeing whether there's a strategy or whether it's ad hoc. So, for example, it's well known in mental health specialist beds. Things like eating disorders, things like that. The private sector actually account for about 40% of all provision that's provided in the NHS, and actually it's a significant national strategic risk if something happens to those providers, which we've sort of seen, versus, if you like, the kind of short-term use to kind of do waiting list management of sort of lower less procedures. They're sort of quite different, but you need to have systems and processes in for both, and be really clear about kind of what your strategy is. So I think it would be quite useful. And also, we've had some challenges with the voluntary sector, who obviously are not in it for profit and everything else, but sometimes their governance structures or information governance structures and things like that can actually trip us up. So give us some time on it, Martin, but I think it would be useful to shine a light on outsourcing, what we've done to date, what we've learned, and kind of, what our strategy going forward is.
Yeah, thank you for that, Julian. No, I don't think it's a sort of panic issue, is it? But I think it's one of those things that we're seeing more of, and we just need to understand what the risks and benefits are, I think, as a board. So we'll leave it to you to come up with a date. Hayley.
Yeah, I was just going to say, certainly in the experience that I had during doing outsourcing in the past, contracts are hugely important to underpin what you do as well. So some quite specialist contract knowledge is often useful as well. So just was going to add that. That's all, really.
That's really helpful. And last week or week before, I don't know if you saw about it, but cataracts, they're almost exclusively done now by outsourced, because they can do mass in separate units. And the Royal College of Ophthalmologists were expressing some concern around what was left in the NHS, and also the training and skill set around it. So again, we can pick up if there is in any areas that we've got, whether we're actually leaving kind of either training, development, knowledge sort of isolated as well. So we'll pick up that risk as well. I don't think we have, but we will make sure we explore that too.
Thank you very much. Well, good discussion. Thanks, Naomi, for raising it. Shall we move on to finance? Paul, item 8.
Yeah. Yes, can do. Apologies, I appear to have an internet connection problem, so hopefully it'll hold long enough for me to go through this this update. So at month 8, I think it's still performing well. We're still in line with where we expected to be at end of this financial year. So year to date, surplus of 600,000, which is 1.5 we planned. You remember in December, we were in the process of responding to NHS England's requests to improve system forecasts in conjunction with the additional industrial action funding that they were providing to systems. Working that through, we've received 550 funding, which were accounted for in month, and we expect that our elective recovery performance will be adjusted towards the end of this financial year. So our year-end performance forecast is due to improve by 1.8 million to 3.1 million. We're just waiting on time to communicate that officially back to NHS.
Already frozen.
England.
Paul, you're freezing. Shall we just come back to you and we move on, come back, see if we can get a better connection?
So, we report.
Paul, can you hear me? I think what we'll do is can someone communicate with him? We'll move on and come back.
550 industrial action fund.
Okay, shall we move on? Julie, have you managed to send something through?
Yes, it's going back in again.
Yeah.
Oh, it's coming in again. Okay, well, wait a second then.
I'm glad this has happened, because yesterday I was having a Teams call with him and he was blaming me for it. And I kept going in and out. I'm sure, and I was thinking, this isn't. I know mine's fine. 3 times I had to go in, so I'm actually quite pleased this has happened. Here we go.
Well, you got better kit as chief executive, you see, Julian. Paul, are you there?
I'm back again. I'm not sure where I froze on.
You better just go through from the beginning again quickly.
Okay, so in month 300 surplus, including 550 industrial action funding, so small deficit in month. Increase in pay costs, 100,000 higher than we planned in month, but still remaining underspent year to date by 1.3 million. Modest increase in workforce of about 32, which is broadly split 50-50 between investment and underlying staff growth. Temporary staffing costs again increased slightly, but we're still maintaining agency spend within a 3.7 target, so we're at about 3.2% overall. Key concerns, no change from what we reported in December, which is around our placement costs. So we've seen an increase in costs over the quarter, peaking in November with average usage of 40 out of area placement beds over the course of the month. This includes use of our pre-contracted beds, as well as 6 planned bed reductions across PPH for quality reasons, which the board agreed earlier in the year. It's come down to 24 today. It should be an improvement, and we are looking at what we can do to try and maintain a lower level of bed occupancy over Q4, but it is going to be challenging and is volatile. In terms of elective recovery funding, we're showing us 100,000 additional benefit from elective recovery funding. As I've said, in line with the agreed reforecast with NHSE, we've agreed accounting treatment for overperformance, so we expect an additional 900,000 of elective recovery funding to feature in the position at month 9. In terms of capital expenditure, we're 2 million behind our agreed spending levels with Bob, so what we refer to as our CDEL target, but we've got a number of schemes that are being approved now and a number of schemes which will deliver and complete during Q4. So we will fully spend to our agreed spending levels with Bob, and the capital spend that we've got outside of our agreed CDEL target, which predominantly is our spend at our PFI providers. We're going to finish the year about 1.3 million behind, but that's entirely around the revised timescales on when our POS programme is going to be delivered at Prospect Park, which is going to be next year opposed to this year now. And finally, from a cash perspective, remaining healthy balance, 56 million at the moment. If we adjust for planned capital expenditure movements to the end of the year, probably expecting to finish somewhere in the region of 48 million. So I'll hold it there and hopefully I'll be able to stay online for questions.
Any questions for Paul? It all seems very very steady still, Paul, in spite of the difficulties.
I think we're in a, as I've said previously, I think we're in a pretty strong position in terms of the way we set the plan this year. So everyone is predominantly outside of mental health inpatients where we know we've got pressures. Everyone else is holding within expenditure plans for this year. So we are at the moment holding ground, and we've got, where we have got pressures in places like out of area placements, we've got some benefits playing through, like interest on our cash balances, which were higher than planned. So we've got things that are netting off some of our pressures overall, but I think it's that management to budgets in year by operational divisions, which is holding us in good stead.
Okay. And will we have a more on capital? Will we have more of a problem next year? You talked about the timing of the POS thing, but I mean, you're spending quite a lot more on IT this year. Will that reverse next year, or was it too difficult to tell?
It is difficult. We know we got a 3-year capital settlement and we're going into the 3rd year of it. So capital allocations at a system level will be broadly in line with what they were this year. So we're not seeing any increases. So we will see the expected demands from all providers on that allocation, and it'll be what we can negotiate. We've also got obviously emerging pressures, which we know we need to do something around, like Jubilee Ward, which we previously discussed, as well as our ongoing IT investment that we need to make. So it is going to be, as ever, it's going to be a challenge in terms of agreeing a capital plan within the allocations that we're given.
Okay. There's no other questions. We'll move on to performance report, Paul, please.
Yeah, fine. So if I just focus first on the breakthrough objectives and the ones that are shown as red. So obviously physical assaults on staff over target at 59 assaults by 23 individuals in the month. I think some positives coming out of that in terms of the work that is being done by the team. Certainly a lot of positive communications from Thames Valley Police in terms of how they're engaging with the staff at PPH. We've had some positive feedback from the police in terms of the approach that we're adopting, and seeing the police in attendance at relevant ward status exchanges, which is an improvement and helping. And I think the general perception from staff over there is that that's really helping, and the work that's been done is making improvements. Senior leadership team are continuing to support increased reporting and helping staff make sure that we're reporting through all of the incidents appropriately. In terms of bed days occupied from community health, obviously challenging time of the year. We're over target at 767 bed days lost against the 500 target, and that's 93 patients driving that, including a couple that have got very long lengths of stay with us. The primary reason for the delays is getting care packages in place, which is obviously a challenge for local authorities who are under funding pressures at the moment, which is no surprise. And we're feeding that back to the system and directly to local authorities in terms of trying to get resolution. That's not to say that we're not looking at our own internal discharge processes as well. And I think Windsor and Oakwood undertook some deep dives over over the past month to look at their processes and have tweaked their discharge processes to make sure we're as efficient as we can be. We've mentioned out-of-day replacements as well. In terms of driver metrics, no real change. Small improvement in I Want Great Care scores, but still below target. And in terms of tracker metrics, again, there's no new areas of concern or no new metrics that have gone off. And if we look at the ones that are continuing to raise concern, it's most probably around the occupancy rates across the mental health wards and community wards, which are still higher than we would want, and probably seasonally we've started to see an upturn in sickness rates as well. So happy to hold down and take any questions.
All right, any questions, please? Mark.
Yeah, not so much a question, but just as an overall comment. I know 18 months ago, we had some long discussions with Jane Nicholson and the team in terms of the impact of retention and holding on to staff with our challenges. And just a compliment really to Jane and the team in the work that they've done, because if you look at the tracker, yes, it's been green on staff turnover on page 34. But it continues to drop 1/3 of a percentage point month on month, and has done for the past 8 or 9 months. And I think the team have done some really good work there that continues to feed through. And we're actually at the point of the target for next year that was set by us as a team. And I think she's to be commended in terms of some really good work in challenging circumstances that other trusts are still struggling with.
Thank you, Mark. I think we all share that assessment. Good news. No, nothing else. Okay then, Paul, thanks so much. It's amazing your IT has stood up. But Green Plan. Now we've got on to something more of a discussion. And welcome, Justine, for this. Paul, are you going to introduce, or should we just let Justine go?
Yeah, I mean, this is the on an annual basis, I want to feed back to the board formally in terms of how we're progressing against our Green Plan. This is the second year of our 3-year plan, final year next year, and we'll be doing some work to develop the plan for the year ahead. Justine's going to present where we're currently at, and obviously we'll feed this into the annual report, which we'll complete in April, May time as well. So quite happy to hand over to Justine to take us through the presentation.
Great, thank you very much. Thanks, Martin. Thank you, Paul. I will just bring up my presentation now. Hopefully that works. Apologies, my laptop is a little bit slow this morning as well. Okay, so I'll try not to make this too much of a repeat from when we last spoke, but just starting off with why we have not only a moral imperative to act on the environment and climate change, but also a legal obligation. So going back as far as 2008, the UK has enshrined into law its net zero target of 2050. Slightly more recently, in 2020, the NHS released its own Delivering a Net Zero National Health Service report, which plotted out how the actions that it must take to achieve net zero. And then a couple of years after that, it became the first health system in the world to embed net zero into legislation through the Health and Care Act of 2022. Within this, the NHS England has set 2 major net zero targets. So first of all, for the emissions that it directly controls, so this is called the NHS carbon footprint. It is legally bound to reaching net zero by 2040, with an interim target of an 80% reduction in emissions between 2028 and 2032. So coming up quite soon for that first goal. But that first goal is a target and not a legal obligation. And then for the emissions that are under our influence but under our direct control, so this is the NHS Carbon Footprint Plus. The NHS has set a target of reaching net zero by 2045, with again an interim target of an 80% reduction by between 2036 and 2039. So thinking beyond the legal case, we also have the human case for acting on the environment. We know that human health and environmental health are inextricably linked. And so when we expose people to healthier environments, we know that they can live longer and better quality lives, and also have better mental health as well. So living in cleaner environments mean that we have fewer cases of disease, things like asthma, even diabetes is linked to air pollution, heat stroke, various other diseases and disorders as well, improved mental health and well-being as well. We also know that having a cleaner environment can help to reduce hospital stays, and also the impact of interacting with nature as well on people's recovery, and also therefore this helps to reduce the burden of care. So the climate crisis has been called a health crisis because it very much is. 13 million people across the world are dying every year because of avoidable environmental causes. And we know that extreme weather events such as, we're all experiencing quite extreme weather at the moment, back-to-back flooding. And we know that this can negatively impact both of our physical health and our mental health. And that also extreme weather threatens service provision, so people not being able to get to work to deliver care. And it also widens inequality, so thinking about things like fuel poverty. And we also know that our dependence on fossil fuels, so energy insecurity is leaving us vulnerable to potential future shocks, which we've seen because of the war in Ukraine. And that means that we will have our precious resources diverted away from things that really matter, to paying our energy bills. So what are the things that we must do? We've got various obligations and targets outlined in the NHS standard contract. So we must reduce greenhouse gas emissions in line with all of the targets that I set out earlier, which are in the Delivering a Net Zero National Health Service. We are obliged to phase out fossil fuel heating and replace fossil fuel heating systems like gas boilers with less polluting alternatives. In the UK, there is also legislation about this as well, and that there will be no new gas boilers by 2035. And that is 5 years later than the original target of 2030. So if there is a shake-up in government, this may well be brought back to the original target of 2030. The NHS standard contract also outlines that we must reduce our waste and water, and we also need to reduce air pollution from our vehicles. So that means that we need to transition to net zero vehicles, low emission vehicles, and also look at our leasing schemes as well and ensure that all the vehicles that we lease are electric as well, which means that we also need to look at our electric vehicle infrastructure. So how are we doing so far? Been tracking our carbon emissions since about 2018. And since then, over the 4-year period, our carbon emissions have reduced by around 20%. So that's about a 5% reduction in carbon emissions every year. But if we are to achieve our 80% reduction target by 2032, we actually need to triple the rate of emissions reductions. And even if all of the projects that we currently have lined up are implemented and successful, we will still be slightly off track to meeting our targets. And so we know that we need to do more. There also is the caveat in these trends that some of the reductions that we have made in our emissions are not directly due to our own policies. For instance, there has been a shift towards more working from home, largely because of driven by the COVID pandemic. We wouldn't expect to see that trend continuing. That's probably plateaued in terms of the number of people working from home. And also grid electricity has shifted much more towards renewables as well. It's not just reliant on coal and fossil fuels. And so that has inherently brought down the emissions from electricity as well. So we do need to bear in mind that some of the gains that have been made aren't directly due to our own actions, but of course some of them are as well. And also it is pleasing to see that the amount of emissions that we are producing per square metre of our sites has dropped quite significantly. And again, some of this, a chunk of this is due to our own actions and the things that we're doing. So, for instance, implementing energy savings initiatives like LED lighting, reducing our consumption, switching to renewable energy tariffs and things like that. Okay, and so just looking at where our emissions coming from, we can see here that there has been a slight shift in our emissions from 2018 to 2022. So you can see that there has been quite a drop in the amount of emissions coming from our transport. So we are doing a lot fewer miles. Also, we have been shifting our own estates vehicles towards electric vehicles as well. But you can still see that the bulk of our emissions are coming from our utilities, and that transport also does make a sizable chunk of it as well. So in terms of our green plan, we've set various goals across major focus areas. One of these is obviously utilities. That's our largest source of carbon emissions. And so in our green plan goal, one of the main things we wanted to do was to install renewable energy. We are now installing solar panels at 2 of our sites. So that is Churchill House and Early House. As a contractor has been chosen for that work, and that's hopefully going to be done this financial year. And we've also commissioned a feasibility study to look at the potential of major solar panel installations at West Berkshire Community Hospital. Also looking to decarbonise our heating. That's a goal to do this across all of our sites. We have applied for a £2 million government grant for heat pumps at West Berkshire Community Hospital. We haven't found out the outcome of that, but we are encouraged that our application is now under scrutiny by the assessment panel, which is generally seen as good news. So we know that we've at least made it through the first stage of shortlisting for that grant, and we should know within the next couple of months whether we've been successful. We've also decarbonisation plans for all of our major BHFT sites that are going to be completed in the coming months. In terms of utilities, our overall consumption has gone up over the years, but also the size of our estate that we're looking at has also increased. So our intensity of energy consumption has actually fallen. So the amount we're consuming per square metre of building. We have been installing LEDs across our sites, and this is an ongoing project. They are much more insensitive than the old fluorescent. They are much more effective at reducing energy than the old fluorescent bulbs. Our water consumption and the intensity of water consumption has actually risen over time, so that's something that we do need to have a look at. But to start addressing this, we have started a pilot trial of some water-saving cisterns which use air to help flush water. And so we're going to be looking at that and whether we might be able to install more of these innovative loos across our estates to help reduce consumption. We are also conducting energy audits across our sites, which will also be completed within the coming month, and that will also include a metering strategy. And this will help us to identify lots of different energy saving measures that we can take across our estate, and also help us to build a more comprehensive net zero roadmap. So looking more detailed at our utilities, this is the data that we have so far. Data for 2023 to 2024 is incomplete, and we are also investigating some rogue meter readings for our water consumption. So please don't panic that there is quite a significant increase in this year. We do expect that to go down once these queries are resolved. But as you can see, our utility consumption has remained fairly consistent overall, but actually the intensity of this has been declining over time, which means that per square metre we are using fewer utilities, which is a good positive trend. Travel and transport. So after utilities, this is the biggest source of our emissions. So in our green plan, we aimed to roll out an EV charging network across our sites. So far, we've already installed 34 EV chargers across 7 sites. We're also getting a rapid charger at London House that's being installed right now. Also, 4 out of our 7 estates vehicles are electric, and 2 more are being transitioned to electric. So that will mean that almost our full estates fleet is electric, which is fantastic news. Another goal was to develop a green travel plan. So we have contracted an organisation called the Energy Saving Trust, who are right now analysing sleuths of data from our trust. And we have also launched our sustainability survey, which for the first time is looking at travel patterns across the trust. And so far the response has actually been quite encouraging for this survey. I was a bit worried that we might have survey fatigue, but so far in the first week of launching the survey, we had 500 people respond. We do ideally want to double that so that we can get about 20% coverage, but it's really encouraging to see that people are engaging, because the last time we ran a sustainability survey last year, 20 people responded. So we're obviously doing something right there. So all of this information will then feed into our strategy that we're going to develop later this year, which is due in 2026. We're also improving how we monitor travel, and we can see that since 2019, people are driving 1.2 fewer million miles a year, which again is an encouraging shift, but we need to do more, and we need to also start to look at commuting patterns as well, which I've already mentioned that we are doing. And also we are working to help promote and encourage active travel, so through the trust induction and through information that we're providing through our Nexus sustainability pages. Waste is another target area for us as well. So we currently have a waste audit commissioned by an organisation called Catalyst, which is now being reviewed, and that will inform the development of a future waste strategy as well. We have also been looking at introducing reusable schemes for medical equipment. So we are trialling a reusable tourniquet called Daisy Grip at the moment, which will significantly reduce waste from taking blood samples. We are also now trialling an insulin pen recycling scheme, which has been implemented in the pharmacy and the community diabetes teams as well. It's also been a goal to increase recycling, which we have done successfully, but on the flip side, our general waste has actually only reduced by 7% since 2017. So that really is not a huge amount, and it puts us behind our target of 10%, which was to be achieved this financial year. So hopefully the waste audit and review will have a look and come up with some ideas for how we can better tackle general waste. Confidential waste is also still far too high. The trends are not decreasing for confidential waste as well. We know that we print far too much. We're printing millions and millions and millions of pages every month and producing tons of confidential waste. This is something that we are now looking at to tackle with IT. In terms of people, we had a goal of developing and supporting a network of net zero heroes or green champions. So getting people who are interested, involved in sustainability initiatives across the trust. We've already recruited 27 since we launched the initiative in September, and they are based across 13 different sites across the trust, which is really encouraging. We meet every month and we have an annual calendar of topics that we go through. And this month we're going to be launching an energy campaign for Energy Saving Week, which runs later in January. We've also been working to improve the content that is on the internet and the intranet. And we've also worked with the comms team to develop a quarterly green newsletter. We have also been increasing the training available to staff. So 33 people across the trust have so far been trained to become carbon literate. It's a really great programme. And this is a training program that I'm able to run myself. So we're saving resources by doing that rather than having to pay a consultant to do that. And I'll be running 2 more training sessions in February and March as well. We've also added more modules onto Nexus as well, so some shorter modules, and sustainability is now included in every trust induction. And we've also developed a green plan to make our infographic of our green plan to make it more digestible for people to understand. And then also looking at our estate, it was a goal to increase tree planting and coverage across our sites. So far we have very recently just planted 15 trees at 2 sites. That's Churchill House and Hillcroft House. And we've got 50 further trees on order, which are going to be planted in the coming weeks at West Berkshire Community Hospital. This is a pilot planting area because we know that West Berkshire can actually house many, many more trees. But provided that this tranche of trees is a success, then we'll be looking to repeat this every year. And earlier last year, there was a new sensory garden that opened at Wokingham Hospital. And we are also planning something very similar at Churchill House, and we've applied for a £110,000 grant to develop a nature trail at Prospect Park, which aims to both support local biodiversity, reduce emissions, and also support people's mental well-being of both staff and patients and their families. I've been working with the head of property as well to develop a sustainability checklist for all new property acquisitions, so that every property that is being considered added to our property portfolio will be scrutinised for its sustainability credentials, and that includes a minimum EPC rating as well, so an energy performance certificate rating. Similarly, we've also developed with the estates team an environmental impact assessment for all capital projects, and this is something that we want to expand with the programme management office for all projects and also for all policies. And we also have a pilot biodiversity survey which is being commissioned at West Berkshire Hospital as well. So away from progress and onto our actions for this year, we have lots of things that we know that we need to do and to continue to work on. So we'll be working with Martin to develop and implement a sustainability section of the new estate strategy. So looking at major areas like utilities and waste and green spaces and travel. We will, once the decarbonisation plans and energy audits are completed, we will be looking at their recommendations to develop a multi-year plan to reduce our emissions from our utilities, which will help us to reduce not only our carbon, but also our costs as well. And then similarly with the recommendations from the waste audit, we'll be using this to implement a waste strategy as well. We're looking to continue our staff engagement initiatives as well, particularly around energy saving, because we know that staff behaviour or people's behaviour in general can make a huge impact on how much energy we can consume. It's actually been estimated that bills could be reduced by as much as 20% just through behavioural changes alone. So this is something that we want to work on with the communications team. We will also be using the outcomes of the travel review to start to build our own travel strategy to help reduce our associated emissions from travel and transport. And included in this will be a continued expansion of EV infrastructure so that we can meet our upcoming targets from the NHS England travel and transport strategy. We'll be looking at further opportunities for solar, and we are also implementing various other strategies and plans, including a clean air plan, an adaptation strategy, and also a biodiversity strategy. That is everything.
Justin, Justin, thank you very much. A very comprehensive presentation. Alex.
Justin, thanks. And fantastic to see the carbon impact trend we've already got and what we're going for. And then hearing from the next one is the travel impact around our footprint. And I was just thinking about the electric vehicle infrastructure. And we've got quite a lot have gone in. When we go around sites, they're not always being used. How do we incentivize the switch to electric vehicle use? So I'm thinking around the lease scheme, kind of where are we on the lease scheme? Could we do some pool cars that are electric for our community bases? So those that are doing community visits, can we pilot something around that? It's looking at our, our good cash balance. We could be sensibly spending some of that to try and incentivize that switch and use the EV infrastructure. My thinking was, if you've got a community nurse that's not sure about an electric vehicle, they get to try one out whilst doing their visits as a pool car. It may knock into behaviour in their own circumstances, change their petrol vehicle.
Absolutely, and all of the above. So one major thing that our travel review is doing is they are looking at where our miles are going from and to, and that will help to identify hotspots. And this will help to therefore identify locations which may be suitable for the implementation of electric pool vehicles. So yes, you're definitely on the same wavelength as us. In terms of EV, the usage of the chargers, we know that it's not an issue that they are oversubscribed at the moment, but with the transition that is expected towards EV vehicles, we do need to prepare for that rather than being underprepared and then them being overcrowded. Some members of staff have already voiced concerns, for instance, at Prospect Park, where there is limited EV infrastructure and people without EVs are parking in the spaces and therefore blocking people from being able to park their cars. So we do know that this is likely going to become an issue in the future, and that's something that we do need to prepare for. Also, in terms of the lease scheme, yes, we're in contact with finance about this. There are some pretty tight targets that have come out from the new NHS England travel and transport strategy, one of which is that there will be no new leased vehicles that are fossil fuel vehicles from 2027. So that's coming up quite soon. There has been a lot of pushback over this goal. A lot of trusts are concerned simply because they can't provide the infrastructure to support this transition because there is not the grid capacity to have enough, to simply have enough EV chargers. So we are tentatively waiting to see whether this might be pared back a little bit, but we are in contact with the finance team to make sure that we can start to think about how we can meet these obligations and targets.
Thank you very much. Naomi.
Thank you, Justine. Another great presentation, and I just feel so good about the fact that we've got you and you're moving the dial. So really appreciate it. I have kind of 2 or 3 questions in no particular order. Can you just help us with the funding of this? We've done some ambitious things and they're expensive. So the investment in EV charging, solar panels, etc. So how does that work, and are you satisfied with how it works?
In terms of funding, this is an interesting and frustrating area in that NHS England comes out with all of these fantastic targets and goals, but no money whatsoever attached to these. So you're essentially completely on your own, which, obviously I am very pro setting these targets to get, to really give us the ambition to make change happen. But it is becoming increasingly difficult to meet such targets when there is no associated centralised funding, which is why we are looking at various other schemes to see what is available. So thinking about things like solar panels, what we might want to do is start to look at power purchase agreements, which is where essentially an external organisation will come along and pay for the panels, and then we pay a below market rate for the energy that's generated for that, which means that obviously they're not free, but we still get discounted energy and it's completely green energy as well. So that's something that we could help in terms of energy. For heat pumps, yes, we have to get off fossil fuels, and this is going to be undeniably the most expensive thing that we have to do is remove all of our gas boilers. And there is limited funding for this, but through the public sector decarbonisation scheme, which is what we've applied for the heat pumps at West Berkshire. You can only apply for one site at a time. Given the size of our estate, there is no way that we are going to have a decarbonised estate by the 2032 target, because if you can only apply for one site at a time, and the chances of actually getting the funding are really quite slim as well, we will need to think perhaps outside the box about what other opportunities might come up about funding for decarbonisation in the future as well.
Yeah, thanks for that, Justine. I mean, without dwelling too long on the subject of funding, Paul, it might be something that we want to take into FIP to look at from a budgeting and slightly longer term strategic perspective, but let's take that offline. My other question, Justine, was about measurement. Have we considered using science-based targets to measure our progress going forward, or a process-driven arrangement where we can be very assured that the measurements that we're using to drive net zero are accurate?
So we have now started to look at the possibility of using external companies for our monitoring. So at the moment, we don't have any sense of our indirect emissions. So the NHS Carbon Footprint Plus, it's not something that we've looked at before. It's something that we do need to start urgently addressing if we are to have an 80% reduction in, we don't know how many tons of carbon by 2036. So there are various external organisations that we could potentially work with to make sure that our measurements are robust. Obviously, these do come at a cost, so that's something that we will need to, again, consider. Various organisations I know are doing this. So, for instance, Newcastle University has worked with Smart Carbon for their emissions monitoring, and what they've also done is they use this to look at their scope 3, so their indirect emissions from their supply chain as well. And they are very positive about that. I'm having a conversation with them soon. So we are starting to think about what we might be able to do. But again, at the moment, there aren't any consistent guidelines from the NHS on how we should be doing this. And actually, there's a lot of variation across trusts in terms of how people are measuring their emissions. So some people actually count zero emissions just by having a renewable energy tariff, but we know that's not the right thing to do. So yeah.
Thank you for that. So great food for thought to use an external agent to support that effort. And then last but not least, and this might be slightly philosophical, but your opening section of your presentation was about the legal obligations. And as we all know, with the legal obligation, there's usually some impact or penalty of not achieving it. Do you have any insight on that? Because this is a bit bizarre, isn't it? The government, we are a government body, or a body that works on behalf of the public. If there are penalties, the government would effectively be penalising itself if we failed, type thing. So that's an interesting one, isn't it? Do you have any insights?
Yeah, I mean, already the government's net zero plan has been shown to be completely inadequate and completely off target. They have been sued successfully by an organisation called Client Earth, which took them to court and found their net zero plan was unlawful. They didn't actually lose any money, but they had to go away and make a new net zero plan. So at the moment, I suppose in a strange way, we can take solace from the fact that the government is missing its own targets, and therefore it's unlikely to penalise us at the moment, because if they're not meeting their own targets, then they can't tell us off for not doing so either. But hopefully things will start to tighten up. But at the moment, I don't foresee that the government would exactly, penalise us financially, certainly.
Thank you very much. I'm done.
Thanks, Naomi.
Thank you, Naomi. Alex.
One more question. Sorry, Justin. It's about our strategy. Are we going to focus on the drivers we can influence, or are we going to go into our supply chain, or at least seek assurance around our supply chain? And one example of this is there's a national drive to move to a centralised national energy contract, for which they are saying there will be sustainability benefits, as an example. We also have all other angles of supply chain. It goes into the outsourcing piece as well, we were talking about earlier in the board today. How do we get assurance over our supply chain and help others and ourselves bank sustainability benefits? Or are we just going to focus on what we can influence?
A bit of both. So already we are implementing measures across procurement. So we have a sustainable procurement strategy, and there's been some new guidelines come out from Central NHS England about procurement, which we are adhering to, so that any new contracts over 5 million, they have to have a net zero plan. So we ask all of our new contractors over this value to assure us that they have committed to net zero by 2045, so that would put them in line with our own goals. Obviously, this isn't the case for our smaller contracts, which make up a lot of our supply chain, but we do still ask organisations whether they do have a net zero plan and carbon reduction plan as well, and then we will score potential suppliers accordingly based on that. So organisations will get a higher weighting if they do have a net zero plan. So we are slowly starting to implement strategies which will help align our suppliers with our goals, but we already do know that a lot of our suppliers are not forthcoming with supplying us with the information that we need to start tracking our associated emissions from our contracts. So for instance, as part of the travel and transport review, we asked our 15 largest suppliers to provide us with contract associated emissions, and only 2 responded to them. And one of the responders I actually got from our major waste company was, we have that data, but we're understaffed, so we're not giving it to you. So this is something that we're going to have to increasingly fight over time. But it will become the case that if people don't supply us with this information, then obviously we wouldn't look to work with them in the future.
Okay, Paul.
It was just on just another point on the procurement thing, which we've got NHSE's guidelines in terms of what we should be requiring of our suppliers. We've currently got a proposal in train, which is going to the next Green Group meeting, which is whether we do something further, just simply because most of our supply contracts are less than 5 million. So actually, if we just capped it at that 5 million level, we'd only be dealing with a small number of suppliers. So do we go further as an organisation simply to increase our requirement on the suppliers that we use? So again, it's showing that we're trying to tailor it to our own supply base.
Okay. Thanks so much, Justin. As you can tell, the board is very engaged with this subject. I think you've given me the answer, but my feeling is that younger staff are probably more engaged naturally. They have a more of a commitment to this. Is that right, or is it all staff? Or
I have seen that our Net Zero Heroes network is quite varied.
Oh, right.
But I mean, in general, it's, you know, the younger generations are seen as being more environmentally friendly. But that's not to say that people of older generations are not interested in this subject at all. And we do know that we need to be reaching all audiences and changing all behaviours and hearts and minds, because, you know, our strategies will only get us so far. If we don't have everybody on board, then we're not going to be able to meet our targets. So we really do need to work on engaging our staff more effectively.
Okay, thanks for that. The other question I had was, in your charts, you showed that the energy intensity per square metre was going down, but our square meterage was going up. And I suppose the question it poses in my mind is, why is our square meterage going up?
So this is just since we started recording quite a long time ago, and we only had very limited data back in 2017, 2018, where we were only recording our energy consumption from a handful of sites. So it may well be that our overall estate has actually not got bigger, but the estate that we are measuring has got bigger. So sorry, I didn't clarify that.
That's all right. No, that's all right. I just wasn't quite sure what we bought in the last few years, you know. And the final thing, which has just come from an old person, is that when I was younger, you know, fresh out of university, etc., nearly everybody went by public transport or cycle to work. Very few people drove. That was in the early 70s. And now everybody drives. And I know they're moving gradually to electric vehicles, but the public transport system, I think, although we can't influence it directly, is still something I think we should, you know, express our views on to those who do control the routes and the frequency of buses and trains and things like that.
Yeah, no, I completely agree. And actually, we've got a really good bus system in Reading, and I think we do need to promote that more, because there's the £2 cap on your transport, which is a really great and efficient way to get around. I don't know whether enough people actually know about that. So no, I completely agree that that's something we should do more. And of course, supporting more active modes of transport as well. So maybe we could look at developing cycling clubs and cycling breakfasts and things like that.
Good idea. Okay, Justin, thanks so much. Really interesting presentation, and we look forward to further work. Thank you very much indeed.
Thanks for having me. Bye.
Bye. Okay, Council of Governors update. I've got nothing to update. It's been Christmas and things like that in the year, so I think we'll move on from that. Any other business? Okay, date of the next public board meeting is the 12th of March. Now we consider our normal resolution to exclude the press and public. Thank you very much, everyone. In terms of timing, Julie, for our next session, we've got Bob